Assalamu alaikum, everyone. I'm Dr. Sairah Sadaf, and I'm working as Associate Professor and Head of Department at Sheikh Zayed Medical College and Hospital Rahim Yar Khan. And joining me today is my brilliant colleague, Dr. Mamoona Shaikh. She is working as Assistant Professor at Liaquat University of Medical Health Sciences, Hyderabad and Jamshoro. We will be discussing a topic that is of much importance for the patient well-being, especially in the environments where resources are very limited. So our podcast will be on acute pain management in low resource settings. For that, I would like to invite Dr. Mamoona Shaikh to have her words. Ji, Dr. Mamoona.
Thank you, Dr. Saira, for having me on this very interesting podcast. It's a privilege to discuss something that we both are so passionate about and something that is so vital for any healthcare professional because acute pain, when untreated, isn't just uncomfortable, it prolongs recovery, increases complications, and simply diminishes human dignity. It's truly labeled as the fifth vital sign, a subjective feeling that we must always believe when reported by our patients and be timely addressed.
Absolutely. Now, when we talk about pain management, particularly in the places like rural clinics or district hospitals here in Pakistan, or indeed anywhere with limited infrastructure, we often face a stark reality. The ideal state of the art solutions frequently are not available. So, the burning question is, do landmark based techniques still stand through the test of time? Dr. Memona, we all know that ultrasound guided nerve blocks are in trend all over the globe, right? So, but I was thinking if any setup does not have an ultrasound machine, so why even bother with a nerve block? Why not simply have a shot of IV meds?
Yes, that's a sentiment I hear a lot. Now, I'm not living under a rock and I know the global trend regarding the surge in ultrasound guided blocks. But everyone is not privileged enough to have an ultrasound machine and proper training to place the blocks at the same time. In my opinion, relying only on ultrasound guided regional and ignoring the place of landmark based techniques is a disconnect from reality.
Okay, so coming back to my question, I would like to ask why are we talking about landmark-based regional blocks when we have other simpler options like systemic medications? For example, we can have IV opioids or even ketamine in low doses. So, what do you say about it?
Well, the fundamental reason, Dr. Saira, is patient safety and superior outcomes. Regional anesthesia offers a lot of benefits like reduced opioid consumption, which means reduced risk of complications. There is better pain control with regional techniques, facilitating earlier discharge, short length of hospital stay, which reduces financial burden. Regional blocks provide prolonged duration of pain relief with fewer side effects. It's become a fundamental part of multimodal analgesia in ERAS protocol. Besides, every patient is not a candidate of opioids, ketamine, or IV meds altogether.
Well, that makes perfect sense. So let's dive into the reasons why these regional techniques are often a better choice compared to systemic medications in low resource settings. G, Dr. Mehta.
Sure, let's compare them one at a time. Firstly, IV opioids. While they are a cornerstone for severe pain, they come with significant baggage, especially without robust monitoring. Complications like respiratory depression can be fatal in unmonitored settings. Other side effects like nausea, vomiting, and sedation prolonged recovery, adding to the workload of already overworked nursing staff. Also, they often just dull the pain rather than truly eliminating it. When talking about ketamine, however, although it's a versatile drug producing dissociative states, but speaking as a primary analgesic for somatic pain, it carries risks like psychomimetic effects, hallucinations, delirium, which are terrifying for patients, and hemodynamic fluctuations that could be dangerous for patients with cardiac issues.
All right. So if those are the challenges with systemic medications, how do landmark nerve blocks offer a better alternative for acute pain in these settings, Dr. Ramona?
All right. So, when we are comparing, this is where the landmark based techniques truly shine. I can enlist them for our listeners. They provide profound pain relief to the surgical site or to the trauma site with minimal systemic effects like respiratory depression or sedation. Patients are comfortable, alert, and can participate in recovery and rehab. They are efficient in resource scarcity. That is, they are resource efficient. All you need is a local anesthetic, a syringe, and a needle. No expensive machines, no constant supply of electricity. This is a game changer for peripheral centers of Pakistan. Now, interestingly, the picture is same in our neighboring countries like India, Bangladesh, Sri Lanka, but I would go a step further to include low resource areas of UK and US, where up to 20% of their population have limited access to health care. So it's a global solution. Also, it leads to empowerment of local clinicians by equipping them with usable skills to alleviate suffering, provide better outcomes in terms of morbidity and mortality for their patients.
Okay, so that's quite thought-provoking. But let's address the elephant in the room that often comes up, the blind aspect and the perceived danger of landmark techniques compared to ultrasound guided blocks. What's your take on this gray area, Dr. Mamoona?
It's a very interesting question, Dr. Sairah, and I'm glad that you asked. Now, I am myself a strong proponent of ultrasound guided regional anesthesia, and no one is denying its incredible advantages, like direct visualization of vital structures, real time drug spread, and avoidance of complications like pneumothorax. But we must also take into account the ground realities. Not every person is fortunate enough to have these machines available. Also, there is a considerable learning curve for sonography and even more so for needling under ultrasound. Lack of trained people, time, and cost constraints are huge limiting factors. However, this should not mean that our patients cannot benefit from regional anesthesia. Landmark based techniques have been forever in our field and they have stood the test of time. Moreover, the term blind is misleading in my opinion because landmark blocks are anatomically guided. They rely on a deep understanding of 3D anatomy, surface palpation, and sometimes nerve stimulation. If rightly done, these landmark based techniques are useful tools, especially in low resource settings.
All right, so I understand your point. So, what about your own experience? You practice ultrasound guided regional anesthesia very much. Why are you still rooting for Larma guided techniques for nerve blocks? Dr. Memuna, kindly throw some light on it.
That's true. I do practice ultrasound guided regional because I had the luxury of trained seniors, availability of ultrasound machines, and logistics working in my favor. But in stark contrast, the place where I work, we have some 45 plus ORs and only two ultrasound machines. So anyone can do the math. There's a huge gap. But again, as I mentioned, this should not be an excuse for poorly treating pain because pain is inevitable, but suffering is optional. So that is the reason why I enthusiastically and unapologetically teach and promote landmark guided blocks.
Well, I can't agree more. So, Dr. Memuna, you mentioned the learning curve for ultrasound guided nerve blocks. What is the learning curve for these landmark based techniques?
Well, if you have a strong knowledge of anatomy, you are good to go. I have residents who watch me do it once, perform it under direct supervision once, and then they are confident enough to do it on their own. Of course, this varies for different blocks, but generally speaking, these are easy to teach, easy to learn, and work just as well as ultrasound guided blocks in terms of analgesia. So it's a win win situation.
Oh, yes, it's a win-win situation, right? So, Dr. Memuna, it just came to my mind one thing. Where do landmark-based technique stand when compared to epidural analgesia? Can you please elaborate that?
Great question, Dr. Sairah. When comparing to epidural analgesia, you don't need any special kits, trained staff, monitoring, or any fancy gadgets to run infusions. Moreover, they are not associated with widespread systemic manifestations. The list is a long one, but if I have to say it in a single line, I would say it's just one nerve or some terminal branches in case of landmark based techniques, while it's almost whole of the spinal cord that we are talking about in case of epidural. So choose wisely. Also, at this point, I would direct my talk to those who discourage landmark based techniques. Whether you realize it or not, but the neuroaxial techniques are also landmark guided, which includes navigating your needle very much close to the cord and other neural structures, as well as epidural is associated with some disastrous complications. Now, we do know that ultrasound guided neuroaxials are being performed in some centers, but that too are ultrasound assisted rather than being ultrasound guided. However, routinely, no one thinks to learn that skill. Then, if we go a step further, for confirmation of epidurals, some centers use the SUI test, which is far superior, but we still practice the loss of resistance and hanging drop techniques. I can go on and on with such examples, but I guess you get the gist of it.
Wow, that's mind-blowing and well justified. I must say you have a strong take on it and you have made your point loud and clear. So, what blocks are we specifically talking about today?
We are focusing on landmark guided facial plane blocks primarily for analgesia, keeping patient safety in mind. These blocks are based on anatomy and body landmarks given in facial planes, so no vital structures are at risk of injury, and they are typically used for analgesia, not anesthesia. So many conditions are well suited, like fascia iliaca compartment block for neck of femur fracture pain, wound debridement and suturing being done with local infiltration or like digital blocks. Rib fracture pain relief can be achieved with simple blocks like intercostal nerve block, serratus anterior plane block, or erector spiny plane block. And of course, how can we forget our good old friend TAP and rectus sheath blocks for post-op analgesia? There is a huge number of studies which suggest that when utilized in surgical ICU patients, improved analgesia leads to better outcomes, which tells us that the horizon is not just limited to ORs, but to emergency departments, critical care units, and so on.
Right, Dr. Mamoona, thank you for such a meaningful discussion. But before we drop the mics, is there any advice you would like to give to our audience, especially those who are working in the challenging environments?
Okay, although we've been talking about the ease and safety of landmark guided blocks, one must not forget that it is an intervention and safety must never be compromised. Always stick to your basics like having an IV line, the procedure being performed in a controlled setting, proper monitoring, having an access to oxygen and emergency drugs, and lastly, do not forget to take consent.
Totally agree with this part, Dr. Mamoona. And well, anything else you would like to say to the hardcore critics of the landmark-based regional blogs to build up your own case?
Well, in our field of medical science, there is never a one size fits all rule. We tailor our practice according to our patients, our own skills, feasibility, working conditions, and institutional practices. With these landmark guided blocks, analgesia can exceed post op NP orders, allowing patients to switch to oral forms earlier. These are usually part of a multimodal analgesia care plan, avoiding opioids altogether. You see, our medical field is evolving and we change it to our benefits. Like, for example, in surviving sepsis guidelines in 2021, it was recommended to give vasopressors only through central lines. But the 2023 updated guidelines now recommend that in low resource settings, you can start vasopressors via peripheral route for at least 24 hours and can go up to 48 hours. So we mold our practice according to the benefit of our patient population, and we should address the fact that not all patients and practitioners are equally privileged, but with patient safety being the center of all this discussion.
Right, Dr. Mamoona, I totally agree with this. And thank you so much for sharing your insights by diving deep into this topic. Perhaps we can have a dedicated activity for demonstrating the landmark-based nerve blocks in future. So what do you think?
I think that's a great idea, Dr. Saira, and I would love to be a part of it. It's always a great pleasure and fun to collaborate with you and your team.
That sounds great. So we will definitely love to have you. Your insights has knocked at the closed doors. And I truly hope that together we can encourage some of those doors to warmly open with a change of mindset. With that, I will add that no patient should have to endure the pain. It is every patient's right to receive pain relief, no matter the settings or circumstances. So, before concluding my podcast, I have a question for you, my audience. Just answer me. What do you say about a 70 years old male sustaining trauma injuries that include multiple rib fractures after a 6 feet fall? He is a known case of severe COPD and presented with altered sensorium. Will you give him IV opioids, ketamine, or thoracic epidural, or any regional block? While you are working at a low resource setting, what will be your choice? Now you will be judge of this situation. And with that, we will take leave. Thank you for listening. And thank you, Dr. Mamoona, once again for being with us today. Take care, everyone.